Monday member statewide call-in meeting. Today we have a special meeting, as those of you know, because in this case you needed to sign up for it, unlike our normal Monday afternoon call-in meetings where you can just show up. So thanks in advance. Again, for those of you that did take the time to register and to participate. I'm going to do just a couple of housekeeping items, and then I'm going to turn it over to the chairs and the presenters. So if you are encountering technical difficulties, I'm going to give you a phone number, and I'm also going to give you an email address. If you would please write these down so that during the course of the webinar, if you're having technical difficulties, this will be the only way that you will be able to get support. The phone number, 312-368-1154. Again, that's 312-368-1154. The email address is RACHELGIELAU@povertylaw.org. So we'd like this webinar to be interactive, and the presenters really welcome your questions. Please keep in mind that we'll answer the questions at the end, and use the question feature on your control panel, please, to submit your questions. After the webinar, you'll receive an email with the link to the webinar resource page where you can find the presentation and other resources. And with this, I would now like to introduce Kathy Chen.
Hi, everyone. On behalf of the Illinois Maternal and Child Health Coalition, thank you very much for participating in today's webinar. My name is Kathy Chan, and I serve as the Associate Director and Director of Policy and Advocacy with the Illinois Maternal and Child Health Coalition. You may have experience working with us on women and children's health policy issues or through one of the projects listed on this slide. Please feel free to visit our website or feel free to contact me to learn more about any of our work. Now I'm going to turn it over to Andrea.
Good afternoon. My name is Andrea Kovach, and I'm a staff attorney at the Sargent Shriver National Center on Poverty Law. I am also very pleased to present to you today. The Shriver Center provides state and national leadership on health policy issues, and we encourage you to visit our website and contact us.
We're going to use the next 40 to 45 minutes to provide you with the big picture overview of the Affordable Care Act and also offer specific information about the changes to Medicaid that will take place in 2014, the competitive health insurance marketplace, also known as the exchange, expected changes to the healthcare delivery system, how immigrants are affected by the Affordable Care Act, provide a few case scenarios as an example of how the Affordable Care Act will work, offer some helpful resources, and then have an opportunity for questions and answers. So this next section is really meant to provide just some basic information about the law. So many of you may already be familiar with this, especially if you have participated in past presentations or briefings with one of our organizations. So on March 23rd of 2010, President Obama signed the Patient Protection and Affordable Care Act into law. 7 days later, he signed the Healthcare and Education Affordability Act of 2010, which made some changes to the first law. Together, the two of these laws are commonly referred to as the Affordable Care Act, or ACA. These laws already have and will result in major changes in the way our country's health insurance and healthcare systems work, as well as provide affordable health insurance to millions more people. So healthcare reform is a big deal. The Affordable Care Act will eventually provide health insurance coverage for 32 million more people who lack coverage today. The goal is to provide families with security and peace of mind that comes from knowing that when they need their health insurance, it will be there for them. According to recent data, approximately 12%, or just over 1.5 million Illinois residents, are uninsured. As a result of the ACA, this number is expected to decrease from 12% uninsured in 2011 to 7% in 2020. The Congressional Budget Office, also referred to as the CBO, which is the nonpartisan scorekeeper of spending in Congress, estimates that health reform will reduce the federal deficit by $124 billion from 2010 to 2020 and $1.2 trillion more in the following decade. And this is all while providing health coverage to millions more people. So remember during the ACA debate and discussion when President Obama repeatedly stated that if you like your insurance, you can keep it? Well, this refers to which plans are affected by certain insurance reforms and regulations. Employer-sponsored plans that existed prior to March 23rd of 2010, and remember this was the date that the ACA was signed into law, essentially remain the same, except that insurers will have to abide by some of the new consumer protections that we're going to talk about. These are sometimes referred to as grandfathered plans. However, insurance plans that were created after March 23rd have to comply with all of the new benefit provisions and consumer protections. Plans actually lose their grandfathered status if they choose to significantly cut benefits or increase out-of-pocket spending for consumers. So this next section, we're going to cover changes to Medicaid that will have a dramatic impact on how many more low-income Illinois residents are going to have access to health coverage. So as many of you know, in order to qualify for Medicaid in Illinois, you have to be part of a category. So this includes being a child, being a parent with a child in the household, being a pregnant woman, or being aged, blind, or disabled. Adults who don't fall into one of these categories are not eligible for Illinois Medicaid, even if they are low income. But in 2014, this is going to change. So starting on January 1st of 2014, the Affordable Care Act expands the Medicaid program to allow for everyone under the age of 65 with household income up to 133% of the federal poverty level to be eligible for Medicaid. Individuals will still need to meet citizenship and immigration requirements, which will be covered in a later slide. Approximately 700,000 new people are estimated to be eligible for Medicaid in 2014. Initially, the federal government is going to pay 100% of the costs for those who are deemed newly eligible for Medicaid. After 2016, the matching rate is going to decline steadily and will level out at a 90% matching rate in 2020 and for future years, which is still well above the current matching rate of 50% that we currently receive for Medicaid. So just to give you a sense of what 133% of the federal poverty level looks like, this chart shows those levels for the newly eligible group of Medicaid enrollees based on household income. As you can see by this chart, a single adult living alone would need to have a household income of less than $14,483 to be eligible for Medicaid under this new expansion. So how does the ACA simplify eligibility for Medicaid? So an important philosophy that's actually being applied to Medicaid eligibility in 2014 is to really remove some of the burdensome requirements that have often been barriers to coverage. As a result, a new income standard referred to as Modified Adjusted Gross Income, or MAGI, will be used to determine eligibility for all subsidized health programs, including Medicaid and the premium tax credits, which Andrea is going to talk about later. However, MAGI will not be used to determine eligibility for elderly individuals, dual eligibles, medically needy individuals, and for those whom eligibility is based on receipt of another aid, such as SSI and foster care assistance, and when an income finding has been made by an express lane agency. Secondly, no asset test is going to be applied in Medicaid for individuals whose income is calculated using this MAGI standard, including parents and other non-elderly adults as well as children. There's also going to be a no wrong door approach, meaning that there's going to be a single application for all health programs. That applications can be made online, in person, by mail, or by phone. That applicants will be screened and enrolled in appropriate coverage option regardless of their entry point, and that no unnecessary information should be required or requested. The ACA sets forward expectations to have a single web portal for enrollment with real-time eligibility determinations using data that is verified electronically. This will allow for the use of paperless verifications by cross-matching information in other state and federal databases, which can allow for a more efficient use of administrative resources and to make it less burdensome on the client. To help states make necessary systems upgrades, the federal government is providing significant financial support for these new IT systems to states. So who are the populations that will be newly eligible for Medicaid? Remember that the newly eligible is going to be anybody who is between 18 and 65, is at or below the 133% of the federal poverty level, meets U.S. citizenship or legal residency requirements, was not eligible for Medicaid prior to December 1st of 2009, And so some of these subpopulations include folks like childless adults, and what we mean by that are adults that are living in a household, either as single adults or a couple, but don't have a child living in the household with them. Young adults aged 19 to 25, which are actually the majority of non-elderly adults that don't have insurance currently. Older populations aged 55 to 64 that are not yet Medicare eligible. Homeless individuals, minority populations, and also some parents that are out there. So what is the system going to look like that's going to help determine eligibility in 2014? Well, EVE, or the Eligibility Verification and Enrollment System, is the process to verify eligibility and also enroll Medicaid-eligible folks through the exchange. This initiative is being led by the Illinois Department of Healthcare and Family Services, but is also working closely with the Illinois Department of Insurance and the Illinois Department of Human Services. Healthcare and Family Services has hired consultants to start the design of their EVE system. The Shriver Center and Illinois Maternal solicited comments from a number of stakeholders, including many of you, who have expertise enrolling individuals and families into public benefit programs, and submitted these comments to the consultants so they could benefit from your expertise in designing EVE. Together, we're also advocating for a way to continue to provide comments and get reports on the EVE design and the public education through the Public Education Subcommittee of the Medicaid Advisory Committee. The Shriver Center and Illinois Maternal will be happy to continue to report on progress about EVE to all of you and solicit your feedback in the event that you're unable to attend these meetings. So please contact either myself or Andrea with updates to those. So when it comes to advocacy opportunities, here are some potential issues that we've flagged to be ready to provide some expertise in the coming months, as well as areas where we hope to get additional guidance from the federal U.S. Department of Health and Human Services through the regulations process. These issues may also be coming to the forefront of your mind as you play out how to help your clients better understand how they gain access to coverage in 2014. The first is whether the exchange will use current income or income from last year to verify eligibility for Medicaid and the subsidies. An open question that requires clarification from federal regulations could have significant impact on how coverage is accessed. We also know that there will be a significant population hovering at 133% of the poverty level or at a higher mark that makes frequent transitions between Medicaid and the subsidized coverage in the exchange. So how can Illinois ensure that these individuals move seamlessly between coverage options while also maintaining appropriate eligibility and ideally staying with the same medical home or primary care provider? The Affordable Care Act also requires that the exchange eventually coordinates with other public benefit programs like SNAP, also referred to as food stamps. So what is this going to look like to the user? State Medicaid departments will also need to identify and distinguish between those who are newly eligible and those who were previously eligible to account for appropriate federal match. The U.S. Department of Health and Human Services does not envision the need to set up separate systems for this. So how will it work for Illinois, and will it be set up in a way to ensure a simple process for initial applications and for renewals? How will complex family situations be handled, particularly when it comes to families with mixed migration status? And Andrea is going to talk later about the classes of immigrants and citizens that are eligible for certain products through the exchange and Medicaid. And last but not least, the Affordable Care Act authorizes a navigator program to help people enroll through the exchange. Once federal guidance is released, states will make their own decisions on what their navigator program will look like. Insurance brokers who have been largely active in the private insurance market are expected to have a role, but so will community-based agencies, which have been active in helping with enrollment into Medicaid, All Kids, and other public programs. What sorts of qualifications will be necessary to become a navigator in Illinois? How will Illinois craft its navigator program to ensure that the uninsured and most vulnerable populations receive enrollment assistance that is culturally and linguistically appropriate? And will navigators be paid for their services? If so, from what funding stream? Now I'm going to turn it over to Andrea to talk about the exchange.
Thank you. So the Affordable Care Act also includes provisions for states to set up a competitive health insurance marketplace or exchange. The idea for the exchange is to help a slice of the public for whom insurance traditionally has been especially expensive, and that's people who buy coverage on their own or as part of small employers. The goal of the exchanges is to make it easier for these folks to compare health plans while at the same time creating pools of customers large enough to slow rising prices. So starting in 2014, in one location, using one application, all insurance plans, including Medicaid, just as Kathy described, will be presented in a clear, user-friendly format that allows consumers to understand plan terms and compare benefits and services across plans to be able to choose their insurance plan from one of the options listed on the exchange. Household income, family size, and citizenship information will be verified through data matching with state and federal databases. And the applicant will input their preferences for the type of insurance plan, and then the exchange will provide the different plans and benefits that meet that criteria. The qualified health plans participating in the exchange are required to have enough providers to cover their patients, are required to contract with essential community providers, and are required to perform well on quality measures. In Illinois, initial projections are that the Illinois Exchange will enroll 486,000 individuals in 2014 and over 1 million by 2016. So what's covered in the exchange plans? The Affordable Care Act mandated that a broad package of essential health benefits equivalent to that of a typical employer plan be offered by the qualified health plans participating in the insurance exchanges. Congress then directed the Department of Health and Human Services to develop a specific list of benefits, and they, in turn, enlisted the nonpartisan Institute of Medicine to recommend a process for defining this package. Just a few weeks ago, the Institute of Medicine recommended that HHS develop, by May 1st of next year, an initial essential health benefits package based on the general categories specified in the ACA and that I've listed on this slide. The package of benefits must be affordable for consumers while covering these basic health care necessities. HHS has announced that they're going to hold a series of listening sessions to gain input from Americans on what specific benefits within these broad categories should be in the final benefits package. So stay tuned. The Affordable Care Act sets aside federal funding for families with household incomes of less than 400% of the federal poverty level to provide financial help in paying for insurance premiums. So if a lower income family makes too much to qualify for Medicaid but still cannot afford insurance, there's financial help from the federal government to help with the cost of the private insurance. Applicants will learn if they qualify for this financial help when they apply for insurance on the exchange. And in Illinois, it's projected that 73% of people who enroll on the exchange will be eligible for this federal assistance. So this slide shows the income eligibility guidelines for this federal financial help. A single parent with 2 children, for instance, would need a household income of less than $74,120 in order to qualify for the financial help to use to purchase health insurance. The Affordable Care Act states that an exchange must be available in each state by 2014. If a state refuses to set up its own exchange, then the federal government will do it for them. States have a deadline of January 1st, 2013 to prove to federal health officials that they are on the path to be ready for these deadlines. The federal government is offering virtually a blank check for states to start building and staffing the exchange. But the states have to qualify for this federal establishment grant, for this blank check. In order to qualify, by early winter of next year, states need to prove to the federal government that they have decided on certain key components of their exchange, such as the governance structure of the exchange and how the exchange will be self-financing after 2015. So how are we doing in Illinois? In Illinois this past spring, a bill was passed and signed by the governor called the Illinois Health Benefits Exchange Law. And this declared that Illinois, beginning in October 1st of 2013, shall establish an exchange to, quote, help individuals and small employers with less than 50 employees shop for, select, and enroll in qualified, affordable private health plans that fit their needs at competitive prices, close quote. So the law also established a legislative study committee to conduct a study on state implementation and establishment of the Illinois Exchange. And this 12-member committee met 5 times during the late summer. And on September 27th, the study committee released a draft report of their findings. These findings related to the governance structure of the exchange and financing the exchange after 2015, when states can no longer rely on federal dollars. With regards to governance, the committee considered 3 different models: a state agency model, a nonprofit model, and a quasi-governmental model. The committee did not choose a specific model, but the submitted oral and written testimony to the committee from advocates and interested parties seemed to choose a quasi-governmental model. The committee did not choose a financing structure for the exchange either. The study committee is expected to issue a final report soon. So many of the consumer advocates supported a quasi-governmental governance structure, as well as supported a financing structure that assessed all insurers offering plans inside and outside the exchange. Consumer advocates also supported a very strong conflict of interest policy covering those who sit on the governing board of the exchange. Such a policy would bar insurers, brokers, and agents from being voting members on the exchange governing board, and would require voting members to represent consumers, small businesses, and diverse, vulnerable populations. Advocates also supported that a bill be passed during this veto session so that Illinois can be on time to apply for hundreds of millions of dollars of federal funding to establish our exchange. If you would like to learn more about the Illinois Legislative Study Committee, please go to the website listed on your screen. There you will find consulting reports on the current state of healthcare in Illinois and on the possible options and directions the exchange could take. You will also find the committee's draft report and comments from advocates, including the Shriver Center and Illinois Maternal. There is also still plenty of time to reach out to legislators about the importance of the consumer-focused exchange. So once you obtain health insurance coverage, public or private, from the exchange, you'll be required to prove to the government that you have done so. And this is called the individual mandate. It requires that every U.S. citizen and legal resident who can afford to get health insurance do so or face a penalty starting in 2014. This provision is critical for minimizing the hidden tax that insured people pay for care for the uninsured through higher insurance premiums and hospital bills. That's because the mandate requires that everyone have health insurance, not just the sick and the old, but the young and healthy people too. And in that way, there will be a broad pool of insured people. And this broad pool will help to balance out costs and keep them under control for everyone. Right now, the average American family with insurance pays over $1,000 a year in higher premiums to cover the cost of care for the uninsured. So next I wanted to briefly cover some of the changes that the Affordable Care Act makes to the way health care will be delivered, as well as briefly cover how this is playing out in Illinois. This slide provides an overview of the most prominent healthcare delivery models in the Affordable Care Act. The first model is the fee-for-service model, where providers are paid a set fee for each medical service. This model is currently being used in Illinois' Medicaid program for most enrollees, as well as in the private healthcare setting. The coordinated care model is where providers are paid upfront to coordinate and ensure the full spectrum of services a patient requires. The Affordable Care Act includes many provisions that reward providers for using a coordinated care model, and the ACA establishes a federal coordinated health care office within the Centers for Medicare and Medicaid Services, or CMS, to more effectively integrate benefits and improve coordination between state and federal governments for dual eligibles. The Illinois Department of Healthcare and Family Services has already started to implement this model for some of its Medicaid population and is planning to have at least 50% of its Medicaid population enrolled in coordinated care by 2015. We're going to discuss this further in a minute. Accountable care organizations coordinate healthcare in one place, integrating primary care, specialists, hospitals, labs, etc. The providers accept joint responsibility for the quality of care and the cost of care that patients receive. The ACA allows new payment arrangements for Medicare and Medicaid for health systems that qualify as accountable care organizations. A patient-centered medical home is a primary care healthcare setting that facilitates partnerships among patients and providers. The ACA includes grants to support medical home models and policies to enhance payment for patient-centered primary care. In Illinois, as many of you know, just under 1.8 million enrollees were enrolled with the primary care provider in Illinois Health Connect for their medical home. And last, we have consumer-operated and oriented plans, or co-ops. These are nonprofit, member-owned health insurance entities that offer qualified health plans based on an integrated consumer-focused model. In a co-op, the same people who own the company are insured by the company. Cooperatives can be formed at a national, state, or local level, and they can include doctors, unions, hospitals, and businesses as member owners. This model is promising for certain populations, such as undocumented immigrants, who can't access Medicaid or buy insurance on the exchange. There is currently $3.8 billion in federal funding available to facilitate creating co-ops. Illinois' current health insurance market is highly concentrated, so co-ops could be a good addition to Illinois' market. In Illinois, House Bill 3236, a health benefits co-op bill, passed the House earlier this year, and the sponsors are working to build the support to pass the bill in the Senate during veto session. This bill, if enacted, would enable small businesses to create their own nonprofit health insurance plans. The cooperatives would be operated and governed by representatives of the business owners and employees enrolled in the cooperative. So changes to the way healthcare is delivered have the potential to provide many benefits to enrollees, particularly for the Medicaid population. If care is delivered smartly and efficiently, it could cure access problems and promote prevention and coordination and better health outcomes. However, if care is delivered sloppily and only to save money, it could damage access, especially for chronic needs. The Shriver Center, Illinois Maternal, and many other advocates are carefully monitoring Illinois' changes to its healthcare delivery system to help ensure that care is delivered in a way that promotes good quality outcomes and increased access, along with the greater efficiencies. So let's delve a little deeper into how Illinois has already started to change the way it delivers health care for its Medicaid population. In 2010, HFS started an integrated care coordination pilot program for 40,000 seniors and persons with disabilities in the Illinois Medicaid system who live in suburban Cook and McCulloch counties. HFS contracted a pay-for-performance payment model with Aetna and Centene Illini Care. This pilot moves away from the current fee-for-service delivery system, and it aims to bring physicians, hospitals, nursing homes, and other providers into a network connected with electronic medical records and other coordination processes. Enrollment is still being phased in, and providers are still joining the network. Advocates are working with Aetna and Illini Care to prevent disruptions in care. Also, Medicaid reform legislation passed in December 2010 specifies that by 2015, at least half of all Medicaid enrollees will be in a risk-based or capitated coordinated system of care. The law specifically notes that Illinois Health Connect, the state's current primary care case management system, under its existing organization, does not qualify as care coordination towards this goal. However, the Medicaid Advisory Committee to HFS is currently discussing what changes could be made to that program in order for it to qualify. According to the Medicaid reform law, payment for the coordinated care program will be based on pay for performance related to healthcare quality outcomes, the use of evidence-based practices, of primary care delivered through comprehensive medical homes, of electronic medical records, and on the appropriate exchange of health information electronically. The next meeting for the Medicaid Advisory Committee, if you would like to get involved in this discussion, is November 18th. So in the meantime, HFS has also launched what they're calling their Innovations Project. The Innovations Project is designed to achieve this 50% care coordination mandate. According to HFS, the first phase of this Innovations Project is for providers only. And HFS's solicitation for proposals is going to be released in January 2012, with the contracts executed as soon as next summer. HFS is requiring development of a care coordination model that includes medical homes and facilitates care transitions or coordination among the various providers. These providers are supposed to include hospitals, primary care providers, specialists, behavioral health providers, substance abuse providers, and dental providers. For the Innovations Project, HFS is prioritizing the senior and adults with disabilities population, as well as the population of individuals with mental illness and or substance abuse disorders. Fee-for-service for medical services will be preserved as HFS is working towards more capitation and care coordination models. In addition to fee-for-service, the providers must have a portion of their fees tied to this coordination or paying for performance. The providers can propose to be paid a coordination fee, which will be based on performance and quality measures, or the providers can propose to participate in a shared savings model. And that's where coordination can result in a portion of shared savings being returned to the providers and the remaining savings going to the government. Or the providers can propose some other risk-based pay-per-performance model. Enrollment will be handled by a client enrollment broker and there will be a separate RFP for organizations that wish to become client enrollment brokers. For human service providers, there is a potential for some of those who are medical care providers to submit a proposal with HFS for this innovations project. Or human service providers might want to submit a proposal to be a client enrollment broker. HFS has stated that they are very interested in proposals that involve coordinating a comprehensive network of different types of care in the community and not proposals that just involve hospitals only. Toward that end, HFS might be interested in proposals that include supportive housing providers too, since there is an arguable medically necessary case that people in transition from hospital stays will need to include some sort of medical component like nursing or pharmacy. Human service providers might also want to discuss with HFS how efficient coordination of care would involve other non-traditional providers too. For example, if you include social workers in a full-service coordinated care network, it could bring down healthcare costs when they provide case management, counseling, or addiction therapies, or when they prevent readmission to hospitals or help avoid ER visits. So HFS plans to have a public meeting this month or early next month to discuss annual performance and quality goals for the Innovations Project. For more information on the Innovations Project, please go to the website on your screen. Another example of care coordination in Illinois is found in the Medical Home Network. The Medical Home Network is a new safety net accountable care organization funded by a local foundation. The Medical Home Network has been in the planning stages for a long time, but began to activate this summer on Chicago's south and southwest side. The network is targeting women and children enrolled in Medicaid who are at greater risk for readmissions. It links hospitals and medical clinics through an internet portal. So here's how it would work. If a Medicaid patient from a participating clinic comes to an emergency room or is admitted or discharged from a hospital, the clinic will receive an alert within 24 hours with basic information about the reason for the patient visit, the diagnosis, the medications prescribed, and a short summary of the care plan. The clinic will contact the patient and offer follow-up care within a week. The participating clinics and hospitals will have a window of recent medical activity, such as which prescriptions patients have filled and which tests have been ordered. I've listed hospital partners and clinic partners for the network on this slide. So here, this next slide shows a snapshot of the landscape of healthcare reform over the next few years. By law, HFS must report to the General Assembly starting in April 2012 on progress implementing the Care Coordination Program. HFS plans to start enrolling newly eligible Medicaid clients in late 2013. And HFS will have to establish care coordination delivery systems prior to the fall of 2013 in order to meet the statutory mandate of having at least 50% enrolled by 2015. In 2014 and beyond, the state-based exchange will be operational for individuals to enroll in Medicaid or private insurance plans. Low to moderate income families will receive premium federal financial help. Most Illinoisans will be required to purchase health insurance coverage unless exempt. At least half of Medicaid enrollees will be in the care coordination programs by 2015. And accountable care organizations and co-ops may be operational. For human service providers, payments for clients currently uninsured will come from Medicaid because remember, an estimated 700,000 folks in Illinois will be newly eligible. Or payments will come from private insurance because so many more people will qualify for affordable private insurance through the exchange. And your currently uninsured clients will hopefully have increased access to comprehensive coordinated healthcare services. Unfortunately, a lot of questions are still up in the air, but answers will continue to come as the ACA implementation continues to roll out. Next, I wanted to provide a brief overview of the impact the Affordable Care Act has on immigrants. So immigrants who are lawfully present in the United States may buy health insurance in the state exchanges. That means that they also could qualify for the federal financial help if they are under 400% of the poverty level. They must obtain health insurance under the individual mandate unless unaffordable or exempt. Health reform will not change current Medicaid rules that require states to establish a 5-year waiting period for lawfully residing adults. Now, states do have the option to waive the waiting period for children and pregnant women, as we've done in Illinois. As I stated, however, legal immigrants not eligible for Medicaid can obtain coverage in the exchange and receive the federal premium subsidies based on their income. In Illinois, it's estimated that in 2014, 139,000 of all uninsured persons are still going to have that insurance status of being uninsured because they are undocumented immigrants. And this is because undocumented immigrants are not able to buy private health insurance in the state exchange, even at full cost. They're not able to apply for federal financial help to pay towards the premiums. So they'll also be exempt from the individual mandate to have insurance. Undocumented immigrants will remain ineligible for Medicaid. However, they do remain eligible for health programs that are available regardless of immigration status. Hospitals will still provide emergency care. Community health centers will continue to provide non-emergency health care. Insurance companies may offer them insurance plans outside of the state exchange, and undocumented immigrants could obtain health insurance through cooperatives offered outside of the exchange. So as you've heard from Andrea, healthcare reform is very complex. So what we're hoping to do in these next few slides is just to provide you with some case scenarios of what it might look like and how somebody might access healthcare and through what venue they might be getting their healthcare from. So this slide is profiling a 56-year-old woman who is a U.S. citizen. She has no dependent children in the household, and she has an income that fluctuates, making her eligible for both Medicaid and coverage for private insurance through the exchange at different times of the year. So this woman's going to be subject to the individual mandate and therefore will be required to enroll in or purchase health insurance starting in 2014. So when her income is at or below 138% of the poverty level, and the reason we're using 138% here is because there is a 5% income disregard when it comes to Medicaid. So we're automatically adding that 5% for that income disregard. So if she is below or at 138% of the poverty level, she's going to be considered newly eligible for Medicaid starting on January 1st of 2014. She's a U.S. citizen, so she also meets the citizenship requirement for Medicaid. So as a newly eligible person, she's going to qualify to receive the Medicaid benchmark benefits plan, which has to include all essential health benefits. And Andrea mentioned this earlier. This would include things like ambulatory patient services, emergency services and hospitalization, maternity and newborn care, mental health, prescription drugs, lab services. And while those buckets of services have been outlined, the specific services have yet to be issued by HHS. But we know that those are the basic pieces of coverage that will be included in that essential health benefits plan. So during the part of the year when this woman is above 138% of the poverty level, but below 400%, she's going to be eligible for federal financial help through a private insurance plan on the Illinois exchange. And so as Andrea mentioned earlier, this means that depending on her projected income for the year,
she could qualify for a particular amount of financial assistance from the federal government to help her cover her private insurance premium costs. So she can accept that in the form of a tax credit up front, or wait until a year has ended to be reimbursed for the amount that she'll qualify for. When it comes to enrollment in Medicaid, this person would be able to enroll in Medicaid in the exchange by phone, mail, or in person, as well as online. So remember that we said that while the exchange is meant to be set up to enroll online, she can also ideally go to a navigator for assistance. Or she can call a toll-free number, or she can go for in-person help, or submit something by mail. She will only have to fill out one application no matter what avenue she decides to use, and then will be directed to the appropriate source of coverage for her income level, be it Medicaid or through private insurance in the exchange. She doesn't need to know what type of coverage she'll qualify for when she applies, and this is what we refer to as the no wrong door policy, which was mentioned earlier. And remember that if the exchange is crafted in a consumer-friendly fashion, she will get real or close to real-time feedback on her eligibility determination.
So our next case scenario is a lawfully present man in the United States who's been in the United States for 7 years with 130% household income. So he is considered newly eligible for Medicaid as of January 1st, 2014. He meets the citizenship requirements as a legal resident who's been residing in the United States for longer than 5 years. As a newly eligible, he will qualify to receive the Medicaid Benchmark Benefits Plan, which must include all the essential health benefits. He also will be subject to the individual mandate. In our last case scenario, we have a U.S. citizen with a long-standing pre-existing condition that has a 375% household income. So this person is an adult and a U.S. citizen who, before the ACA was passed, couldn't afford or qualify for insurance on the private market because of the pre-existing condition. So now this person in 2014 will be subject to the individual mandate and therefore will be required to enroll in or purchase health insurance in 2014. The insurance plans will no longer be able to deny coverage or charge higher premiums because of that pre-existing condition. So this person will get insurance from the exchange, and because they're under 400% of the federal poverty level, they'll be eligible for the federal financial help to put towards purchasing that private insurance plan on the exchange.
So we hope that this presentation has provided some basic information about the ACA. There's also several other resources that IMCHC and the Shriver Center recommend as additional points of interest. If you haven't already visited the www.Healthcare.gov website, we encourage you to do so. It's a very user-friendly website that provides a lot of great information about the ACA. Consumers can see what private insurance plans are available to them depending on their age, state, current coverage, and health conditions. There's also information about public programs like Medicaid and how reforms in the new law affect people soon, such as small business tax credits, high-risk pools for people with pre-existing conditions, and the ability of young people to join or stay on their parents' plan until age 26. It also includes rates, coverage exclusions, and other pricing information about insurance. Another fantastic local resource is Illinois Health Matters, which is at www.illinoishealthmatters.org, which numerous organizations, including Illinois Maternal and the Shriver Center, contribute to. Illinois Health Matters is a one-stop shop for consumers, providers, policymakers, and members of the media for blog entries, fact sheets, reports, and videos on the ACA.
So that concludes the presentation portion of the webinar. And please, again, feel free to submit your questions in the few minutes that we have remaining. If we receive any questions after the webinar, we will make sure to answer them and submit our responses to the questioner as a follow-up. And again, we wanted to remind you all that all presentations and additional resources will be posted on the webinar resources page, which you're going to receive an email link to.
So right now, looking at the board, the questions that were being asked, we are going to handle offline. So there doesn't appear, we'll wait a minute or two to see if any additional questions come up on the board for us. If not, I will extend my thanks again to Kathy and Andrea before we sign off. But we'll wait a minute or two here to see if questions do pop up on the board. Also, just as a reminder, Illinois Partners will have available this webinar for those after today to be able to access. We have a question or two coming in, Andrea?
We are looking right now.
Can you go to the question of how will reform affect reimbursement rates for providers?
Well, the Affordable Care Act does, for the years 2013 and 2014, bring the rate for primary care providers in line with the current Medicare rates. So at least for those 2 years, there will be an increase in rates for primary care providers, and that's funded under the ACA.
Great. Next question. Can you explain how this would affect a person who currently is receiving Medicaid because of their disability?
That's going to be a complicated question. I mean, we do know that people who are in the Medicaid program and have a disability will be targeted for the care coordination programs that are currently being implemented by HFS. But they will remain eligible for Medicaid under the ACA. They might have a different benefits package, but that is all. There's a lot of open questions still as to that.
Thanks, Andrea. What about Medicaid waiver folks?
I think if that questioner could be a little bit more specific in resubmitting their question, we can answer that question offline.
Great, Lisa, thanks. Last question, how does this affect the Illinois Healthcare for Workers with Disabilities? I guess that's probably similar to the earlier question that was asked about how the disability population will be affected on that.
Yes.
Great. So before closing, let me again just tell folks that have emailed the questions up here, we will follow back with you offline on the email. And if you didn't get an answer to the question and you would like further explanation, please submit that as well, and we'll make sure between Andrea and Kathy, we'll get that information back to you. So again, in closing, let me say my sincere gratitude and appreciation to Kathy and Andrea for doing this presentation, and thanks to you for signing up, and thanks to you who sent us an email of thanks letting us know the presentation went well and that you were grateful for how succinct and informative it was. Again, Illinois Partners will have the webinar available, as well as the resources for this after this webinar. And we will be getting you an email out about our next call-in meeting, which will be in time for veto session, to be talking about veto session and what's going to be happening and what kind of advocacy we need to occur for that. So again, my thanks, Kathy, Andrea.
Our pleasure. Thanks for having us.